Assalamu alaikum wa rahmatullahi wa barakatuh. Today our lecture is about inflammatory bowel disease. In this lecture we'll talk about definitions, the epidemiology of the disease and how to treat it. And we're going to touch about the natural history. Inflammatory bowel disease from the definition is a chronic inflammatory condition that affects the large intestine, what we call the colon, and in that we call it ulcerative colitis. And there is another part of the spectrum of the disease, what we call is Crohn's disease, where it involves any part of the GI tract. We have to differentiate between the two illnesses because there is several pathologic types and clinical phenotypes of the disease. Let's start with the basic. The GI tract usually has 4 layers. The inner layer is the mucosa, then followed up by the submucosa, followed up by the muscularis propria, then the serosa. Usually in ulcerative colitis, the inflammation involves the inner layer. That's a normal depiction of the GI tract, and it looks normal, while in ulcerative colitis, the mucosal layer, the inner deeper layer of the mucosa of the GI tract wall becomes inflamed and ulcerated. With that, what happens that it's thinned out, and lots of crypt distortion happens, leading to probably thinning out of some part of the mucosa, while other parts are not thinned out, formation of what we call pseudopolyps. You can see the difference between the image of a normal mucosa in the colon of normal crypt pattern, and what happens with that crypt distortion, crypt hyperplasia, and inflammation. In Crohn's disease, the inflammation is transmural, so it involves any part of the layers of the GI tract, starting from the mucosa, extending all the way up, and sometimes with that deep ulcers occurs and fissuring happens, and fissures can extend beyond the GI tract to neighboring organs. And with that, what we call cobblestoning, as like what you see in the marble of the streets, the appearance of the GI tract becomes cobblestone. Key differentiating is the pattern of the disease. In ulcerative colitis, the inflammation usually affects almost always involve the rectum. And if it's limited only to the rectum, we call it proctitis. But if it's extended beyond the rectum to involve the sigmoid, we call it proctosigmoiditis. Sometimes the inflammation in the colon affects only the left colon, and we call it distal colitis. But if it extends anything beyond the splenic flexure, it's called pancolitis. And this differentiation now to the Crohn's disease. Crohn's disease can affect any part of the GI tract, and the majority of the cases are related to the ileocolonic disease and small bowel disease. Colon only involvement, it only occurred 1/5 of the patients. So for some certain time, we can label the patient as ulcerative colitis or undetermined colitis, and over time it evolves to a Crohn's disease. We knew it's Crohn's because it involves different other parts of the GI tract. As we mentioned, ulcerative colitis by definition only affects the colon. And Crohn's disease, because of the depth of the inflammation, can cause stenosis, can cause fistula to other organs between the colon and the any part of the GI tract, with the enteroenteric fistula, enterovaginal fistula, enterourethral fistula. All of this can happen. But the clinical presentation of Crohn's is quite different based on the way that the disease behaves. One clinical feature that is unique and That's why we pick up some patients of Crohn's disease is the formation of non-caseatic granulomas. So the clinical presentation of ulcerative colitis, it's probably that because of the inflammation of the colon, majority of the patients will present with diarrhea, rectal bleeding, tenesmus, and passage of mucus. Some would have crampy abdominal pain and loss of weight. Remember that lots of these patients suffer from ongoing to the bathroom and they need lots of time spent into the bathroom. This has probably will cause psychological disturbances and put pressures on the patients. Uh, in addition, that complications can happen from the inflammation. If the inflammation is so severe, loss of hemorrhage can happen and perforation and strictures. Well, another complication of toxic colon, when the inflammation is so severe, the colon becomes so dilated and is about rupture. That's an ominous sign of inflammation. Because of the ongoing inflammation, people and the diarrhea, people tend to lose lots of nutrients and malabsorption can happen. And with chronic inflammation, the cells in the colon may behave differently, and the risk of colon cancer is much higher in inflamed colon. We always have to differentiate ulcerative colitis from acute colitis, anything related to infectious colitis, which is much more common than ulcerative colitis, especially bacterial or viral gastroenteritis. And remember, the diagnosis of colitis or IBD is a chronic disease, so you'd expect to see the patients when you have prolonged diarrhea. Unfortunately, this also leads to the delay of the diagnosis of these patients and contributes to the delay. But always remember to rule out other causes and put in the differential diagnosis in your mind. The clinical presentation of Crohn's disease is quite variable. There are several patterns of the disease. There is this fistulizing disease that only perianal fistula that can present. Fistulas around the anal area that discharges mucus and pain, sometimes perianal abscesses, but that's only could be the presentation of the patient. But a certain population of the patient presents with inflammation. When the TI becomes inflamed, people would get abdominal pain, tenderness, diarrhea, and weight loss. And this diarrhea could be not necessarily bloody diarrhea, as in the Crohn's, in the ulcerative colitis. A good proportion of patients present with obstructive symptoms because of the severe inflammation or fibrosis, cramps, abdominal nausea, vomiting, and it's not uncommon that we seek the diagnosis of Crohn's disease only after surgery that happen. But some of the patients has internal fistulization and they can present with stool in the vagina as in the case of enterovaginal fistula or stool in the urine as enterovesical fistula. So it's quite variable the way the presentation of the patient and how the disease behaves. We can differentiate between the two diseases because of the sum of the clinical findings. We understand that perianal disease is rare among ulcerative colitis, but common in Crohn's disease. Fistulas also is not unlikely to happen in ulcerative colitis, but it's quite common in Crohn's disease. And abscess formation and strictures are much commoner in Crohn's disease. Well, in colonoscopy, you can almost always see the rectum involved in ulcerative colitis. But in Crohn's disease, it's usually spared. So when you see an inflamed area in the proximal colon while the rectum is normal, it suggests to you that's Crohn's disease. And usually the pattern of the disease is in the involvement. In ulcerative colitis, the disease is quite continuous, starts from the rectum and proceeds proximally, while in Crohn's disease, there is skip areas of normality between abnormal areas of the mucosa. And almost most of the patients with Crohn's disease have ileal involvement, while it's an uncommon phenomena, what we call backwash ileitis in ulcerative colitis. And by definition, the the ulcerative colitis only involves the colon, but there is some certain patients that we see some inflammation that extends down to the up to the ileum, but not necessarily that's Crohn's disease or probably related to backwash ileitis. And in histology, obviously, Crohn's disease transmural, you only see that in surgical specimen after resection part of the GI tract, while in ulcerative colitis it's quite superficial to the first mucosal to submucosal area, and is we rarely see granulomas in ulcerative colitis, but it's quite common in Crohn's disease. So we can understand that inflammatory bowel disease or chronic inflammatory bowel disease is a spectrum of two diseases: Crohn's disease on one side and ulcerative colitis on the other side. In the middle, there's a good proportion of patients that cause undetermined colitis. And assessment. Crohn's disease and ulcerative colitis has some extraintestinal manifestations, commonly involving the eyes and the mouth. You can see mouth after ulcers and stomatitis. Uh, Episcleritis can happen. Kidney stones, usually that associated with Crohn's disease, some hepatic steatosis, biliary tract diseases, and gallstones formation is much higher among patients with inflammatory bowel disease, while primary sclerosing cholangitis is particularly a unique phenomenon. Uh, it can precede ulcerative colitis by 10 years. It almost always happens with ulcerative colitis. We don't know what's the association between the disease, but it's a very strongly associated. While we don't see pretty much ulcerative, we don't see pretty much of sclerosing cholangitis happening with Crohn's disease. It's much rarer there. Joint involvement is quite not uncommon with inflammatory bowel disease with skin involvement. So lots of mouth ulcers, we see disease activity, like these are small ulcers that happen in the mucosal layers, and about 5% of patients will develop ocular manifestation as episcleritis and anterior while acute arthropathy affecting the sacroiliac joints and ankylosing spondylopathy, and in particular the ankylosing spondylitis is usually associated with HLA-B27-DQR8, and so there's a strong HLA association with that. In the skin, there's this phenomenon of pyoderma gangrenosum that affects the tibial aspect of the leg and the extensor surfaces, and it's quite dramatic. And usually, they don't respond to surgical debridement; they even get worse. And their treatment is anti-TNF. They work very well for them. Erythema nodosum, which usually happens like a small reddish nodules in the feet and in the extensor surfaces of the legs and the arms. It's quite tender, and they correlate with disease activity too. And we discussed. Let's talk about the epidemiology of the disease, and the incidence is probably quite variable according to the geographic distribution. Um, uh, there is a bimodal selection of the disease presentation. Usually, it goes up in the 60s to 80s and much more in the younger age group between 15 and 30. We don't know why this bimodal penetration. There is no sex predilection for any of the diseases. Probably we see more in females in Crohn's disease. But there is particular association with smoking. Smoking seems to may play a role in decreasing the activity of ulcerative colitis, while smoking can has a good relation with Crohn's disease and exacerbate disease. So we always discourage smoking anyway because of the tremendous health impact of smoking, but that's a phenomenon that you understand, and especially in particular with Crohn's disease patient. Oral contraceptive seems to increase the relative risk of Crohn's disease, while appendectomy seems to be protective against Crohn's disease. There is some genetic component to the disease, and we know now that the NOT2 CARD15 gene, which is although incomplete penetration, has a role in the heritage of this disease. You can see that this disease distribution is probably the hot area are the European and North American areas. Much hotter than the rest of the world. But nowadays, we're seeing more and more of inflammatory bowel disease cases in Saudi Arabia, and we can compare that to 20 years ago, that we all rarely see cases now. We have a good number of patients in Saudi Arabia, ranging between 5,000 to 7,000 patients. Over time, there is temporal trend that there is a decrease in infectious diseases. We've seen that, but there is an increase in the autoimmune disease, and probably that is related to the overall theory of hygienic changes. The primary sclerosing cholangitis. So it's part of the workup that we look into patients, we look into their bloods, we look into the fluid count, because we expect that with the bleeding, they develop anemia, or malnutrition, they develop malnutrition effect. CRP gives us an idea about the inflammatory changes that is happening there in the blood, and it goes with this probably disease activity, but some of the patients will not be able to produce CRP, so it has some role in the evaluation of the disease activity. It's very useful to look into, but it's not an absolute rule. We have to look into the renal profile of the patient's effective diarrhea on the electrolyte balance and liver enzymes to pick up if there is any involvement of the liver with the disease. Stool culture and microscopy is part of the evaluation. Remember that infectious colitis can happen alone and can mimic a flare-up of inflammatory bowel disease. So it has to be taken in consideration. While an important tool that nowadays is used is fecal calprotectin, is a protein that is produced by the WBCs of the colon, and gives us about an idea about the disease activity. And it's a good surrogate marker of inflammation in the GI tract. Some of the antibodies are useful to identify between ulcerative colitis and Crohn's, in particular anti-Saccharomyces cerevisiae antibodies and P-ANCA. Both of them could be has the reverse ratio. So if P-ANCA is low while Saccharomyces is high, is usually associated with the ulcerative colitis versus Crohn's. So um, that's a soft one that people used to use in the older days. Now we pretty much rely on the clinical presentation of the patients. But that's of an interesting association that you may come across. Abdominal X-ray is very useful to find out if there is any viscous perforation in the evaluation of the GI tract. And ileocolonoscopy is probably a standard procedure to examine the ileum, terminal ileum in Crohn's disease, and the colon in the ulcerative colitis. CT abdominal and pelvis is quite important, and sometimes to evaluate complications of the disease as perforation or stricture, and could be part of the evaluation, but because of the radiological risk related to it, so we try to minimize it. And we've replaced so many investigations like small bowel through and X-rays with MRI angiography because of the much more powerful field yield of the examination. And MRI angiography is very useful in assessment of the disease activity in Crohn's disease patient. Probably it has a very limited role in ulcerative colitis, but is much more powerful tool in the evaluation of the Crohn's disease in the small bowel. And MRI pelvis is useful sometimes to look into the perianal area when assessment of perianal fistula. And if needed, upper endoscopy could be done, but lower endoscopy, and that's a standard thing in the evaluation of the patient. This is a normal looking mucosa of the colon, and this is how it looks like in mildly inflamed colon. You see the its appearance of the reflection of the light, the nice vascular pattern that we see here. While here there is like mottling appearance, and here is much deeper ulceration and with significant edema in this picture. Let's go. The radiological investigation is quite important in the evaluation of these patients. So we on the older days we used to use small bowel follow through or bowel enemas to examine the GI tract with contrast. So the patient either injected contrast or the anus or the rectum to inflate the whole GI tract with contrast and evaluate the terminal ileum to find out if there is any stricture. This has been replaced with the neurotechnology like CT enterocolitis, where the patient swallows contrast and we good visualization of the CT of the GI tract. And lately, now MRI has probably took over because it's a much lower radiation risk related to the MRI and the better images, and give us an idea about involvement of the small bowel and outlines of there. So that's part of the assessment. So you do clinical assessment to the patient, and you do radiological assessment, you do biochemical evaluation of disease activity. We rely a lot on radiological, clinical, and biochemical and endoscopic feature. And several scoring systems are out there, but the most famous one is endoscopic scoring system in ulcerative colitis. Give us an idea about the disease activity. So a MAIO 0 is a normal looking mucosa with low profile of the patient, no clinical symptoms. It gives us an idea that the disease is in remission, while a MAIO 3 with lots of patient complaints on the scoring here, it can tell you that the disease is much more active and you need to intervene faster. This is remember about the part of our evaluation of the disease that we look into surrogate markers, and the calprotectin that we described before is as a good surrogate marker of inflammation in the GI tract, and we can use it. But in the quite important in the way that we treat these patients, because the principles of our therapy that the treatment is sequential therapy. So the main goals is not cure. We're not aiming for cure, but we're trying to induce remission and maintain that remission. With these goals, you maintain the patient's quality of life and you restore their nutritional balance and you try to heal the inflamed mucosa. And with that, you prevent, of course, complications. You try to minimize morbidity and maximize the patient time spent on health and productivity. That's the main goals of therapy, and you try to time the surgical intervention as much as possible. We rely on lots of these clinical parameters, endoscopic parameters, biochemical and radiological parameters to give us an idea about disease activity. More of the clinical remission and endoscopic remission, all of these are the primary targets nowadays. And we use these surrogate markers from radiology and biochemical to help us to reach that target of being resolving all the clinical symptoms of the patient and to heal the mucosa of the GI tract, because we know now that healing the mucosa is something, a good outcome that we want to achieve, and it correlates well with the prognosis of the patient. This is an outcome that we try to avoid. The stoma, that's something that we always try to avoid, and we have to base our judgment based on the natural history of the disease. We know over time if majority of the patients are having low uh, profile of disease, but some over time will progress to colectomy and the need of surgery, and that's without intervention. That's for ulcerative colitis. While in Crohn's disease patient, if we leave them without therapy, one third of them becomes disabled. That's from historical data a long time ago. Over time, because the disease behavior. The disease in the beginning starts with an inflammatory component, but over time, there is with the chronic inflammation, things change to more fibrotic stage, and there is a point that if you intervene early, you may prevent this structuring. The probability of surgery over time in Crohn's disease increase steeply, similar to what you've seen in ulcerative colitis. And by the time when you reach 20 years in the diagnosis, if you are untreated in natural history, then there is an 80% chance that you had at least one or more. And the disease course is quite variable. You see wax and wanes in the disease in clinical presentation, but what's happening in the mucosa, there is a progressive rise in the inflammation and change of the behavior of the disease over time from inflammatory to more structuring disease, leading to complications later on and lots of surgery. We assume now the disease onset already started before the clinical presentation, and by the time that we patient presents at this stage, he lost a valuable time that could have been done to prevent complications and fibrosis of the GI tract. The options of therapy are quite variable. We can use from antibiotic, aminosalicylate, to steroids, to nutritional therapy, immunomodulators, monoclonal antibodies, and surgery. All of these are in the menu. I'll just show you the menu that we use of drugs that are has been approved up to 2018, and there is more drugs on the way. So several drugs of 5-aminosalicylic acid and steroids, the topical budesonide or antibiotics, or more systemic steroids can be used like immunosuppressants, azathioprine, methotrexate. So many of these therapies are available and have been tested and very useful. But sees the main biological therapy that made a breakthrough in the way that we treat these patients are anti-TNF, infliximab, adalimumab, and other anti-TNF. While anti-alpha-4 integrin like vedolizumab are quite highly selective in the GI tract, and interleukin 12 23. All of these medications are available commercially, and we've been using it on patients. And recently, stem cell transplant has been used to close up fistulas. So you see with this menu of options, you have to understand which one to choose. Let's go a step further and understand why the disease happened. The disease is a combination of things. We understand there is probably a genetic predisposition and a change in the microbial flora that lead to immune dysregulation and barrier dysfunction. This happened over time. So for a reason that a causative agent has attacked the GI tract. We don't know this agent yet, but this has led to activation of the immune system, and with the activation of the T cells and T helper response, the immune system has been quite activated, and lots of inflammation is ongoing on in the GI tract, leading to tissue injury. So we have this antigen in the area in the lumen of the GI tract was took over and took over by the antigen presenting cells and presenting to the immune system that called on other cells to produce more leukotrienes to share their part in the inflammatory scene. And these leukotrienes and cytokines are all coming together to recruit each other to enhance the inflammatory response to this antigen. So interventions are probably directed to these interleukotrienes. What we described before is anti-TNF is the first generation of leukotrienes that has been targeted and successfully worked well. IL-1223 is another target that has been tested. Alpha-4 integrins are anti-leukocyte trafficking agent. It just prevent leukocytes from trafficking from endothelial cells down to the tissue and trying to minimize that injury. People has worked into the lumen, so probiotic, prebiotic, antibiotic has been used. Probiotic as chemicals, uh, prebiotic are chemicals that has been used to change the bacterial flora, and probably by doing that, and probably the working theory these days, that if you change the bacterial flora and microbial change, you're going to change the environment of the antigen and you restore the balance of the antigens and there, and you prevent inflammation, and from the first time, from the beginning, you decrease the whole injury. So prebiotic is a chemical that has been used, but it's very limited clinical data on it. Probiotic has been there and has been shown in weak clinical studies that it can work in mild disease, while antibiotic has been used in mild disease and control of complications. And recently, stool transplant has been used to change the bowel flora by restoring the bowel flora from an healthy individual. You can probably gonna restart or reset the immune response system. So people are working in that line from within the lumen of the GI tract. That's also a play for the nutritional therapy. In pediatric, we know that nutritional therapy, especially when you use the polymeric or elemental diet, these can decrease the inflammatory response within the GI tract and has been shown to be very effective. So nutritional therapy has a role in pediatric and some extent into adults, but more intensely that anti-inflammatory changes or medications that decrease the inflammation are quite common in the utilization in the medication and planning of these patients. And the whole idea is you want to restore the balance between anti-inflammatory and pro-inflammatory cytokines. Steroids is a very common thing, has been used, and it probably you're gonna see it in your practice has been being used in lots of induction. They're good for induction, They're bad for maintenance, they lose efficacy over time, and they have a very toxic side effect profile. So we do not like to use them for a prolonged period of time. If we're gonna use it, use steroid, use it for a short period of time and try to get rid of it as soon as possible until you bridge to a real that effective therapy is much safer. The first molecules that appeared was infliximab from anti-TNF, and that was in 1998. It has a component from a mouse and the human. Of course, because it's an antibody, over time the body develops antibody against this antibody and then neutralize it and makes it inefficacious. And we've seen that across the board with all anti-TNF. The second generation anti-TNF was fully humanized. Unlike the first generation was the intravenous, the second generation was fully humanized and subcutaneously every 2 weeks. And then the third generation of anti-TNF and fourth on all has tried to modify with the, in their therapy. In principle, we use the step-up approach versus the top-down approach. Most of physicians will use accelerated step-up. When you start your therapy with the basic medication and the down of the pyramid like 5-MeO salicylate and antibiotics, and we use steroids if we don't improve with this. It is presenting with severe illness and you don't want to lose time with the step-up approach. You can use the top-down approach, but either one, most people now are going into an accelerated step approach based on the clinical presentation of the patient. Of course, mild disease, you don't need to use aggressive therapy. So a mild disease, usually a typical therapy will work, as we mentioned in proctitis or distal colitis. Why do you need to use more aggressive therapies if you can do it with lots of topical therapies? But more severe cases like more severe ulcerative colitis that has lots of diarrhea and bloody diarrhea and um, pancolitis, then a more aggressive therapy to these type of patients would be likely more useful to fast put them in remission in a faster way. And steroids has been used, other medications like cyclosporin or anti-TNF now has been to the Crohn's disease. So if you have a mild disease, some 5-amino salicylic acid can work and topical steroids or antibiotic. But in more moderate disease to severe disease, you're gonna move on quickly to probably either a top-down or an accelerated step-up approach to the therapy of these patients. And there is always remember that there are some patients that may not respond to clinical treatment and they'll probably need surgery interventions at some point in their course. So you have to have involvement of the surgeon in the course of the treatment and preferably multidisciplinary team of surgeons, inflammatory bowel disease specialists, and so on in the care of the patient, psychologists, nutritional, psychiatrists. All of these are integral part of the treatment of the patient's inflammatory bowel disease. So in summary, IBD is a heterogeneous group of disease. It has unknown etiology. There is lots of component of genetic, autoimmune, environmental factor has affected the disease. It is a common GI presentation is getting commoner in different parts of the world and causes major disability with a complex course. And the TNF and biologic therapy was a breakthrough in the treatment of these patients. And treatment options are increasing, and the menu and the options for patients are available, and what they need is a multidisciplinary care from psychological support and community understanding of their disease behavior. Thank you very much.